Desi Dunia Network. DDN is bringing you a series of discussions and talks from various health professionals on the health and well-being of Indian population, migrant population settled in Australia. For this inaugural program of this series, we are fortunate enough to have with us Dr. Sadanand Anvekar, OAM, Order of Australia medal winner. This honor has been given to him for his outstanding contribution to the health industry and his philanthropic activity for the Indian community. He is a leading cardiologist, consultant and physician at Austin Hospital, Melbourne University, Heidelberg, Victoria. Welcome to DDN, Doctor.
Thanks, Umesh, for having invited me to your inaugural medical event of DDN. It's been a great honor to be a part of it, and thanks you once again.
Doctor, I know that you've been here for more than 40 years in Australia and settled in Melbourne, and you are the right person to bring some insight into the health and well-being issues of Indian migrants that are settled in Australia. I would like you to tell us how they have settled here and what are the common things they face in their day-to-day life, and can you please elaborate a bit more on this, please?
Yes, Umesh, you are quite right. I have been in this country for more than 45 years. I came to Melbourne, Victoria late 60s. At that time, the Indian migrant population was a small one, mediocre one, and we even didn't have a separate identity in the Bureau of Statistics publications, and we were categorized as other communities. Those things have vastly changed now, and since the last couple of decades, the Indian migrant population is one of the fastest growing population in Australia. Along with the growing population, we also naturally inherit additional health problems, health issues as well. As you would appreciate, most of the Indian migrants are professionals, doctors, engineers, teachers, and since last decade or so, people working in information technology and computer technology and scientists. These people are very well educated. They come from middle to upper middle class families from India, and having settled here in an affluent society, Western society, with secure jobs, they also inherit some additional health problems. If you want me to list these health problems in order of priority, the first and foremost disease that is affecting our community from the incidence of death and disability point of view would be still cardiovascular disease, in layman's sort of language, heart attacks, followed by cerebrovascular disease, again in common language it will be strokes, and then the risk factors like high blood pressure, hypertension, diabetes mellitus would be in that particular order. Because we live longer now with improved sort of health conditions, we also inherit increased incidence of cancer in our population. For example, breast cancer in women and prostate cancer in men need to be seriously considered. And it is very important that we diagnose this condition in early stages so that we can get on top of the disease process and improve the survival in our Indian population in this country. Now, having the Indian culture and traditions are a bit different while we are in our own country, but when having settled here, we are exposed to Western culture and their attitudes as well. And this has created some additional problems of increased stress and strains in life, leading to anxiety neurosis and depression. So from that point of view, we have to consider the psychiatric aspects of the diseases in our Indian population. And again, as I mentioned to you about the exposure to the Western culture, particularly our children in schools and colleges and also at university level are exposed to fast food and illicit drugs, and therefore the childhood obesity has become an emerging sort of a health issue, particularly in our younger generation. And also they face the use of sort of illicit drugs, not that common in the Indian sort of population, but still it is an emerging problem, and that also needs to be sort of addressed. And that would be my sort of a brief outline as to what health issues the Indian population is now facing.
So you mean to say that it is the lifestyle issues and the job stress and day-to-day demand on the lifestyle adds this problem too. And what about the women and children? Is it common to all, or is it different? Do you distinguish between the white population to the Indian population? How do you see it, doctor?
Yes, that's a very good point. Because we are coming from India, our physical sort of stature is not as body mass is not as large as the Caucasian population. So our calorie requirement, the nutrition requirements are different than Caucasian population. But having settled here, being exposed to that kind of eating habits or lifestyle habits, we are exposed to additional problems because change in our lifestyle. This applies to everybody, men, women and children.
I see. So is it common in the old age or the young age, and what one should do to prevent this sort of a thing? Do you suggest going to the GP and regular checkups and things like that, doctor? What do you say?
Yes, Umesh, I think let's concentrate on the largest sort of culprit, the disease, as I mentioned, cardiovascular disease, in other words, heart attacks. And this used to be common in sort of upper middle age and older age group, but not anymore because of change in our lifestyle and the eating habits. I have seen patients as young as 25 to 30 years old presenting with heart attacks. And therefore, the cardiovascular disease or a heart disease is not due to one particular factor. There are culmination of various factors leading to sort of hardening of the arteries and ultimately leading to the heart attack. And these factors would include high blood pressure, hypertension, history of smoking, diabetes, excess weight gain, obesity, and then there will be genetic factors. Unfortunately, we cannot control the genetic factors. We can't choose our parents. But on the other hand, all the other risk factors can easily be sort of identified and treated. Therefore, as you alluded in your sort of discussion, it is very important for our population, for both men and women above the age of, let's say, 35, to visit their GPs on a regular basis, at least once in 6 months or 12 months, get their blood pressure checked, and if it is high, to be treated properly, their sugar levels checked, their cholesterol, lipid levels checked, and definitely take care of their body weight by way of nutritional healthy diet and regular exercise. If you want me to sort of elaborate more on this heart disease, I'll confine myself because of the time constraint to the heart attack presentation as such. The clinical presentation would be the common or hallmark of the symptoms would be the chest pain. The typical chest pain with a patient presenting with a heart attack or angina, what we call angina pectoris, will be a crushing central chest pain, which usually precipitated by any kind of a physical exertion and then usually radiating to a left arm or to the jaw or to the back. That would be a typical sort of presentation, but we don't get typical presentations all the time. I have seen patients just complaining pain and some sort of abnormal feeling, what you call the paresthesia, in their left arm. Some of these patients having been suspected some kind of arthritis, and the actual diagnosis could be very well be missed. Most commonly, because the chest pain is the central, and if it is a little bit lower chest pain, it can be easily mistaken for hyperacidity or symptoms of an ulcer, and people can ignore those symptoms. Usually the tendency is, oh, this is not going to happen to me. But my suggestion would be any kind of chest pain for which you are not used to, particularly it comes on any kind of a physical exertion, and there is constantly there, do not ignore it. It's better to get a medical attention straight away. Either you go to your GP or emergency sort of health clinics, and if nothing is available, if it is out of hours, definitely go to the emergency department of a public hospital, so that let them work it out, sort it out for you. If it is happens to be nothing serious, nothing cardiac, you can come home laughing. On the other hand, if it is a genuine problem, they can take care of it for you in the early phases of the disease. And similarly, along with the chest pain, you have got associated other symptoms, like you feel clammy, or you get excessive sweating, you feel dizzy, or you feel faint. Then that means there is some sort of a compromise going on with your cardiovascular system, and therefore that kind of a patient needs to be taken to the emergency department straight away without wasting any further time. And my advice would be to call the special ambulance, what we call MICA, and they can even start treating these patients in that, and while they are being transported by an ambulance. And once you either go to the emergency department, the doctors have a look at you, or you go to the GP clinic with this sort of symptoms, and it is up to your doctor to investigate them further. And these investigations are very simple, very straightforward. First of all, the doctor has to take a complete history, and he has to analyze the symptoms, and then has to give him a complete physical examination, including checking his blood pressure, and then he can order a simple ECG. The simple ECG may not tell you what's going on unless he's having a heart attack, but then he can send you to a specialist cardiologist who can employ an exercise stress ECG, or he can do an echocardiogram or stress echocardiogram. Then there are some tests can be done in the nuclear medicine field, like a thallium scanning, and these are the kind of investigations will confirm whatever you are suspecting in relation to the underlying heart disease. And ultimately, one can employ an angiogram. You might have heard this sort of very commonly nowadays, by which you can inject the dye into the arterial system and take actual pictures of the arteries, and that will tell us how the arteries are working, whether there are any blockages, how many blockages are there, and depending on that, we can plan further sort of management in these patients. Just briefly coming to the how do we manage this sort of a disease, there are three ways of addressing this management. The one is the medical treatment, and the first treatment would be to identify the vascular risk factors, which I mentioned earlier, like high blood pressure, treat that properly, diabetes, again you have to treat that very thoroughly, the weight, and on top of that the lipid levels. We've got agents to sort of control these sort of risk factors. That becomes part of the management in all patients. And then we've got three other ways of tackling this from the treatment point of view. The first would be a medical line of treatment. There are some special kind of tablets available. You might have heard this name, anginine tablets, which can be employed under the tongue, or it can also come in the form of spray that can be employed as a symptomatic relief. On top of that, there are some special kind of medications, beta blocking drugs, calcium antagonists, and coronary vasodilators can be employed for the management of either what we call ischemic heart disease. And if the patient is presenting with an episode of what we are suspecting a myocardial infarction, as I said, the early sort of attention is very important. If the patient presents to you within the first 6 to 8 hours of the onset of the disease, we can employ special kind of intravenous administration, what we call the thrombolytic agents, which they dissolve the clot, and therefore you can prevent any further damage to the heart muscle. Similarly, these patients can be immediately taken to the cath lab, an angiogram can be done, and either they can be opened up, the arteries, the blocked arteries, or the arteries which are threatening to block can be opened up by putting sort of a balloon angioplasty and then ultimately putting a stent. And this also becomes a part of the treatment in other patients who are presenting with the symptoms of angina without myocardial infarction. And then ultimately, if there are many blocks involved and the arteries are not amenable to angioplasty or for putting a stent, and these can be referred to the cardiac surgeons for what we commonly, you people have heard that particular terminology, like a bypass surgery, can also be employed. And that forms, in briefly, the way these patients present to us, and then how we investigate them and how we treat them.
That's a very good insight, Doctor. Are these procedures quite complex, or are they reasonably simple enough? So how do people see that once they find that the disease is confirmed, and people are usually a bit scared that they need to undergo a big treatment and things like that. How do you see, Doctor? Can you please tell?
When I first started my medical career, we didn't have all these facilities available to us, all these investigation facilities available to us. Angiogram was still not on. Forget about the angioplasty and the stenting and the bypass surgery. All these started in early 70s or mid 70s. And since then, there have been exponential advances in the technology. The technology has improved, the side effects, the complications have reduced, and therefore we can employ these sort of investigations and the treatment very safely. The incidence of any kind of complications is reduced to the minimum. Now we do these sort of investigations like angiograms and then followed by angioplasty and stenting very routinely. Every major hospital have got their cardiology, interventional cardiology sessions, mornings and the evenings. A hospital like Austin would be doing a minimum of about 15 to 20 procedures a day. And this is going on in every major hospital. So that means it's a very commonly done procedure. And with the advanced technology, experienced sort of cardiologists, interventional cardiologists, the risks are minimal. Therefore, I don't want the patients facing this kind of investigations not to think twice, just leave it to the experts. And there are very good centers, particularly in a country like Australia, where the medicine is in an advanced sort of phases. There's nothing to fear about. Then as far as the bypass surgery is concerned, there are experienced cardiovascular surgeons, and they sort of employ these sort of techniques very well, and the cutting edge of the technology and our experience is nothing less than anywhere in the world. So I can vouch for that.
As I mentioned earlier, coronary angiogram is the final test and the gold standard in the diagnosis of coronary artery disease. In the next few slides, we will show you the pictures of coronary angiogram. In the first slide, you will see the normal left coronary artery system. LM is the left main trunk. LAD refers to left anterior descending artery, and the CX refers to left circumflex artery and their branches. The next slide shows the normal right coronary system as depicted. RCA is the right coronary artery, RPL is the right posterior lateral branch, and the PDA is posterior descending artery and their branches. As you would appreciate, these arteries are very smooth, of normal caliber, without any kind of stenosis or coronary artery disease. In the third slide, we will show you the critical stenosis involving the LAD or the left anterior descending artery, as shown by those arrows. And these stenosis are the result of culmination of all the vascular risk factors we discussed earlier on. And the last slide shows the response or the result of the coronary intervention, in other terms, angioplasty and stenting, resulting in normal, back to normal coronary arteries.
That's a very, very informative knowledge what you shared with us today, Doctor. And I would really thankful for your time today for our viewers, and we would look forward to see you for our forthcoming talks and discussions on this health and well-being series. And I once again thank you from DDN. Thank you, sir.
Thank you very much, Umesh. As I said, it has been a great honor and a privilege for me to be part of your program, and I hope your viewers, I was some assistance for them to understand just briefly the underlying sort of principles of this the most common disease, cardiovascular disease, and then I wish you all the best in the forthcoming medical events as well. Thank you.
Thank you, Doctor.
Welcome.
Good. Yeah. And in the forthcoming events, we will be bringing again on different issues like cerebral vascular disease and women breast cancer and psychological issues for children as well as adults, and our series will continue. Thank you.